What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of clinical practice. So that's the standard lighthouse intro, but we have an alternate name here. Dr. Crowe, thank you for coming back to the podcast. This is the inaugural episode of Between Two Nerds. Now, I think that is just an amazing title. CJ was on Dr. Winckler was on our last episode, and he said, you know what y'all need to do? You need to set this up as Between Two Nerds, kind of like Yakamaikas, whatever the poor dude's name is.
Zach Galifianakis.
That's him. And instead of between the two ferns, it's between the two nerds. So
if you have to explain a joke,
I know exactly. It's lame already. We have Dr. Heidi Abraham. She is the Chief Deputy Medical Director in the city of Austin. Heidi, thank you so much.
Yeah, my pleasure. Thanks for having me.
It is. I have known Heidi for a really long time. And I just got to apologize. This is the first time you've been on the pod, and that's just sheer negligence on my part.
Mere oversight. We'll forgive it.
I appreciate that. See, she's such a nice, warm human being. Thank you so much. All right, so Dr. Abraham, there you were.
2 o'clock in the morning.
2 o'clock in the morning. As Jim Page, he wrote an entire book, The Magic of 3 a.m.
There is some magic.
If y'all have,
there is no magic at 3 a.m.
You know, last episode we got CJ dropped some literary pearls here. He recommended Joseph Heller's Catch-22.
Okay.
CJ recommended literature.
You mean like the redneck CJ that we had
from East Texas?
Yes,
the
from
East Texas CJ?
That's the one.
Okay.
Yeah.
The bar's high.
Had CJ read the actual book or like the Cliff's Notes, like children's version?
He probably saw the Netflix.
Probably saw the Netflix special.
Oh, he's not here to defend himself.
That's true.
CJ, I'll defend your honor.
The funny thing, he is so easy to make fun of. The dude is brilliant.
He's brilliant. He's
really
absolutely brilliant, which is why you can get away with making fun of him.
And he's such a good guy. So what we did then is he said, well, let's try this thing. We will bring somebody in to sit in the promised seat between the two nerds and be the clinician. And what I'm going to do, clinician, is start you off with a scenario. There you the literature reference, just being consistent and not staying on track.
What is happening?
Chasing squirrels.
Swimming after doing this at
exactly.
6 o'clock on
he came up with a literature recommendation. So the recommendation today is Jim Page's The Magic of 3 a.m. If you haven't read it, you got to read it. Wonderful book. And I swear to God, the first person who says who is Jim Page, go look him up. So that's our literature recommendation. There you were, 3 a.m. You get a phone call. Dr. Abraham, this is Jeff. I'm Medic 42. I got a 75-year-old patient in a nursing home, long history of dementia. This was an unwitnessed arrest found in a systole. We've been doing CPR for 25 minutes now, persistent to systole the entire time. Never had ROSC, never had a shockable rhythm. We've done all the things. We have him intubated. Our initial End-Tidal CO2 after intubation was around 35 and has been 50 for the past 22 minutes now. I think this is futile. The patient was in a systole. It was an unwitnessed arrest. But I'm really worried about this End-Tidal CO2. I normally at this point would call for a termination, but I'm just worried about that End-Tidal CO2.
Okay.
What should I do, Dr. Abraham?
Okay. Couple questions. Did you give any meds besides epi?
Well, right before the End-Tidal, yes, I did. I was going to be a smartass, but yes, I did. I gave bicarb.
Jeff Jarvis is smartass.
Never. Not a thing.
I gave bicarb.
Okay.
And because I work in a state-of-the-art system, I also gave some aminophylline.
Whoa.
Sorry.
Did you beryllium too while we're at it?
I did. I hear beryllium.
Well, this makes
5
things
milligrams per
complicated.
kilogram repeated at 10 is great for a systole.
I had to look up how to spell beryllium last week.
Oh, yeah. No, that's because you're not old. So, no, we just, we started epi, gave him an epi bolus, put him on an epi infusion. We did give some bicarb early because this was an unwitnessed arrest and a non-shockable rhythm, but that's been 15 minutes since we gave the bicarb.
Okay. So I would be comfortable still terminating at this point.
Okay.
Generally speaking, in a patient with an unwitnessed arrest and asystole, I think there's some good literature out there that already says those two factors make it highly unlikely that we're going to see a change in outcome.
Okay.
I would also feel comfortable saying the bicarb is probably explaining a little bit of that bump in the End-Tidal. Do we have ultrasound in this system?
We do, as a matter of fact.
Okay. Are we sure it's been asystole the whole time? Do we think there's any chance it was a fine V fib? Any benefit to throwing the ultrasound on and seeing if there was...
I don't think so, but hey, I don't think it's going to hurt. So
well,
hold on
I'm not.
one second,
I'm not a
Doc.
fan.
Let
I'm
me
not a
see
fan
here.
of ultrasounding asystole. I think that one's a little pointless. But if we think it might be a fine V fib,
Well, I got a student with me who needs some
perfect.
experience.
Let's throw it on there and see.
This is a beautiful view of 4 chambers that are not moving at all. We're not even seeing any valve quiver.
I'm very comfortable terminating at this
Okay.
point.
All right. Let's terminate. So, Dr. Abraham, the real question I have is you completely ignored the value, the predictive value of end-tidal CO2 in this case. So there was persistently elevated end-tidal CO2, and we know that if end-tidal CO2 goes up, there has to be a pulse spec. So if there is persistently elevated end-tidal CO2, that must mean that it's good, right?
Normally, I think we're looking for a jump, like a significant jump in End-Tidal, right? You went from what 35 to 40.
Yeah, I probably should have done it with more of
little
a
bit more
jump.
of a- yeah, bigger jump.
In hindsight.
Yeah.
Okay, so you're not you were not biting on that elevated end-tidal CO2.
So
in this
I'm not in a case like that, like the unwitnessed arrest, the asystole. Where I would be more bothered with a high End-Tidal like that is if there's some kind of PEA, if we were in a shockable rhythm, that kind of thing. But asystole,
Fair point.
yeah.
So I think one of the other things that we frequently overlook here is what was the patient's pre-arrest status? Because at best, the world's best EMS system, we do everything right. At best, they're going back to baseline.
Right.
So the best that I can tell is I'm not aware of any literature, maybe I'm wrong, that says CPR cures dementia or cancer. Probably not going to get better than they were before.
You should see our Austin numbers. We're doing some truly fantastic things here. And by the way, we're hiring a new medical director sometime in the next couple months if you're interested in applying.
Blatant plug. I have you on.
Shameless
What do you do?
plug.
Love it.
But that's a good point, right? Because so if I have a patient who was like a COPD, patient with COPD, and their End-Tidal lives at 50 at baseline, and they go into cardiac arrest, well, chances are there was some element of respiratory depression before they coded, so their End-Tidal may be even higher, and maybe we go from like an End-Tidal of 70 to an End-Tidal of 50, and that's still an appropriate time to terminate the arrest at that point.
So you're saying that the factors, the physiological factors driving the end-tidal CO2 might be more than just perfusion.
Yes.
There might be something else
Yeah.
involved. Okay.
Yeah.
So clearly we use end-tidal CO2 all the time for our non-dead patients. We use it to confirm placement of our invasive airways, but we also use it to look for signs of bronchospasm,
Right.
retaining CO2, all of those things. If you see a great big 500-pound patient who just makes horrible respiratory noises on the best of days, and you find them unconscious with an end-tidal CO2 of 90, you might have identified the problem there.
Yeah.
So there are other things. It's not just a matter of perfusion. Well, Dr. Crowe, I think what would be helpful is if we were able, this is a literature podcast, we're the nerds here.
I'm stuck between y'all.
You are stuck between us. To bring a little literature to this, and I have this paper in front of me, and as I'm looking at the author list, your name seems to be on it. Of course,
Weird.
Heidi, what is your pre-test probability that any paper that I am interested in, that Remle's name will be on the paper? I would say it's probably
There's a
throwing
very
up.
high pretest
Very
probability.
high.
Yeah.
Well, the name of this paper is the Association of Prehospital End-Tidal Carbon Dioxide with Survival Following Out-of-Hospital Cardiac Arrest. This was published hot off the presses, 2024 Prehospital Emergency Care, PEC. And Remle, tell me who your co-authors are. I know some of them. I like some of them, but there's this lead author that just pisses me off. Who are your co-authors on this?
Well, that lead author is the future Dr. Tanner Smida.
Oh, no wonder I hate that name.
And then we've got the Dr. Jim Menegazzi,
Yes.
Dr. Dave Salcido, Dr. Jim Bardes, and Dr. Brent Myers. And this
Awesome.
has long been a passion project for Dr. Myers, which you may or may not know, but he has been really wanting to look at this concept of, is End-Tidal still as predictive as we once thought it was? And Tanner made that dream come true, like he does.
Thank you, Tanner.
Yes,
Yeah,
thank you, Tanner.
dude, I am so freaking jealous of you. I think I've bitched about Tanner on this pod before. I've had Tanner on as a guest. The reason we're talking shit about him, he looks like he's 12. And he has outproduced all of us. The dude is just cranking out some solid literature. It would be, I mean, is it too much to ask that he could at least be an arrogant jerk?
He's not, though.
No,
it's really
apparently
unfortunate.
it is too much to
He's
ask.
super
He's
nice.
so nice. You really just want to hate him. But I can't. Tanner, great work, man. One more really strong work. So I think Dr. Myers, I share his concern about this. When I started doing all of the terminations in 2011, I was really bothered by this. We would see patients with persistently elevated end-tidal CO2 like this. I've terminated arrest in patients with end-tidal CO2s for the last 40 minutes above 80. And they're still dead.
Yeah.
So the big question, the historical information, what we know about this is that what we've known for a long time, basically since a paper in the New England Journal of Medicine in 1997 by Levine said, if at 20 minutes of resuscitation in patients with PEA, your end-tidal CO2 is less than 10, that means they're dead. It is futile. That paper showed 100% sensitivity, 100% specificity. Oh, but wait, there's more. 100% negative predictive value and 100% positive predictive value, which almost guarantees if you repeat that again, you ain't getting those same numbers. But we've used that forever, and that's all we've used. The other that really informs us about this, the other things that we have just come to believe is that a sharp spike, like you were talking about, is indicative of a potential for ROSC, assuming everything else seems like maybe there is ROSC, including, that there actually being ROSC, like you have a pulse. Turns out we can check for that. And we've also assumed that higher end-tidal CO2s are better. And we've never really known what to do with these high CO2. So I think that may have been one of the things Brent was really driving us on. So, Remle, would you mind just kind of running through what your methods were? Not shockingly, this is an ESO dataset paper.
This is one of the papers that leverages the ESO Data Collaborative. And in this one, we combine multiple years of data, so from 2018 to 2021, looking for patients who are in cardiac arrest. And this includes children. Some controversy there.
The wee ones and the large ones.
The wee ones and the large ones.
Controversy just about the ethics of including kids, or controversies about the bicarb, or about the CO2 levels?
Yeah, about the CO2 levels, about differences in pathophysiology. But we decided, all right, we're going to start with a bigger population, and we can do subgroup analyses if needed. And then we removed patients who were in traumatic cardiac arrest and circulatory arrest, right? Just because that, again, is a different patient population and probably different things going on with ETCO2, so we didn't want to introduce that level of noise.
And all the things we do in medical arrest, completely pointless in traumatic arrest.
Very different
epi
approach,
and
right?
CPR, not an issue. So
And
beasts.
different standards
Absolutely.
of when the arrest is
Yeah.
over. Once you've
Different
done the
beast
interventions,
completely.
you're done.
Termination's very different, yeah.
So what'd y'all do with that? You had that group. You selected dead people not from trauma.
Dead people not from trauma, right? And we wanted to look at EtCO2 is obviously our primary variable of interest, the exposure variable or the independent variable of interest. And then we had some outcomes. And in this data set, we're very fortunate that we have the linked hospital data through the health data exchange. So we don't rely only on the pre-hospital outcomes. Those are still important, things like ROSC, but we actually look at mortality and where the patient was discharged to as a proxy for neurologically intact.
So I want to talk about that just a little bit here. By the way, we're here in person again. You live down here, Perry, Austin.
Austin adjacent.
I now live in Fort Worth. So we're in person. You know, we plugged the hell out of Kalahari and the Texas NMSP conference. Was that really last week?
No, there was a couple weeks. Yeah,
2 weeks ago.
All right.
Time flies when you're having fun. But
it was fun.
Dementia also has that impact.
Where are we now?
That's a great question.
I know.
Planet
Let me
Earth.
check my phone.
Hold on. We are at the JW Marriott, Austin downtown, at the ESO WAVE conference.
Outstanding. Well, you obviously work for WAVE, work for ESO, who puts on WAVE. I don't. Heidi doesn't. So let me just say, this is a great conference. I love this every year. It is a great way to bring together two of the things that I'm very passionate about, data and patient care, data and clinical medicine, and harnessing almost like using the power of data
to improve something.
Yeah.
What's that?
We've hit on your mission before, and the fact that I think it's one of the best missions I've ever heard that really says what your company does. But great conference because you get to do these two things.
It's where the nerds go.
It is. It is where the cool kids hang out. The MD Summit, where the medical directors get together, we spent a lot of time talking about this particular thing. Your health data exchange does not have things like CPC 1 or 2 scores, MRS, modified Rankin scores. So you had to use a surrogate measure.
Right.
Will you tell me a little bit about what you used? Because there's no dead or alive. What did you come up with? How did you group those?
Right, and I think this is an important point, and we look for things like a CPC or a Rankin, but it's important to think about when those things would get entered. They're typically entered by a registrar, not an ED physician. I don't know how many modified Rankins or CPC scores you've entered in one of your EMRs. It doesn't happen. So we do need a variable that gets collected at the time of that emergency department and then for inpatient encounters. And what that variable is the discharge disposition. Now, every facility can set their list. There is no NEMSIS. Oh, and they do. There is no NEMSIS for the hospital. We've talked about NEMSIS on this podcast, I know, before. But there is no data standardization in that way. So what we had to do is create the standardization, and we collapsed into categories that look like the CMS categories. So Centers for Medicare, Medicaid have categories of dispositions, things like discharged to home, discharged to hospice, discharged expired, which means dead. It's my favorite way of saying dead, I think.
Celestial discharge.
Transferred to another acute care facility or long-term care facility. So these were the things that we took into account, and we say, hey, if you were picked up at home and discharged to home, it's probably a good proxy for neurologically intact.
Now, what I think, I like some of the things you did. What if you were picked up at a nursing home?
We wouldn't expect you to get discharged to a home.
Exactly,
Right.
because CPR
It matters
doesn't
where you
fix
started.
dementia.
Yes.
Yeah.
Yes.
Okay. And then you also looked at the impact on ROSC, I think.
Yep. And there's actually I like this argument that's out there is, well, we should be looking at the thing that is proximal to the EMS encounter. I have more control over what happens closer to the EMS encounter, whereas hospital practices may confound or change our results for the long-term encounters. After somebody's been in the hospital for weeks, how much did EMS care play a role in that, or how much was it the hospital care?
Yeah.
So having both of these looks is a more robust analysis.
I like it. What was your clinical question?
Does EtCO2 predict basically futile resuscitation? We use mortality as that marker, but that was the real question, is this still a great predictor for when I might think about terminating?
So, well, I'll come back to this. So let's just going through the paper here. I'm looking at your consort, your figure 1, and I believe you started off, if I remember, just to give us an idea of how when we talk about big data, outside of Amazon or Google, when you're looking at clinical data, the number that you have here, you have 286,000 out-of-hospital cardiac arrest, which was a really small part of the overall data set. I think, did I see 36 million?
That would
rows?
probably be about right. So we're looking at approximately 9 million 911 records per annual data set. And when we include things like the interfacilities, it goes up to 12 or 13 million a year.
And this was 3-4 years worth of data, so huge.
And I think the even more exciting piece of this is, what was once a magical unicorn of I'll never get a hospital outcome sent back is now commonplace. So we're seeing over 1.5 million outcomes per year.
I like it. I like it. So you ended up, after your exclusions that we talked about, 117,000, and you broke those into those with ROSC, those without ROSC. Looks like you had ROSC in about 39%. Interestingly, about 3% of those patients with ROSC did not get transported.
As somebody who has gotten a high-risk refusal on a person we brought back to life, I can confirm.
Absolutely. Well,
and there's
you look
this
at
thing
it,
called rearrest, and I think Tanner has a paper
exactly,
on it.
He does, something like 40%. Again, schmuck. You're thinking, well, you got ROSC and you didn't transport? Yeah, it turns out, when we think about it, we all know this, ROSC can be transient. I terminate after ROSC all the time. You've been in a systole for 30 minutes after ROSC. Nice try. Then you excluded out patients without HDE data because you needed the outcome to
For the measure of mortality, right.
So let's take a look at what we found. Y'all found. I wasn't involved with this.
You were there in
paper.
spirit, I'm sure.
I was there. It was. You had your spirit animal. You had Jeff coming along going, yeehaw.
What would Jeff want to know?
Well, it turns out Jeff wants to know exactly what Brent wants to know here. So when you're looking at the question, do high CO2 levels or low CO2 levels, or just right CO2 levels, baby bear,
That was Goldilocks, but yes.
Shit, sorry. Are they?
There's your literature reference for the.
I keep thinking of the Charmin commercial.
Jeff needs to go back and reread his pediatric literature.
I know. Oh God, isn't that the truth? This is what happens when you work when there are children's hospitals everywhere. You don't see kids anymore. What did you find, Remle?
In this paper, there were a couple of interesting findings. One of them is better looked at in a figure. We can see that there's a clear U shape, no matter if we're looking at the minimum EtCO2 value or the maximum. Yeah. And so it seems that there maybe is a Goldilocks effect of maybe there's this nice spot in the middle. Too low is bad, but too high also seems to look bad.
And the figure we're going to pop up on screen if you happen to be watching this on YouTube. By the way, did you know this podcast is on YouTube also?
I did not know.
It is. So
the more you know.
It is figure 2. This was your End-Tidal CO2 at 20 minutes, or as close to 20 minutes as you can get. And what you're looking at is the different categorical ranges of End-Tidal CO2 versus mortality, or survival, I'm sorry.
Survival.
So high is good, low is bad. Both sides of this curve, you got a U on both, whether you're looking at the highest or the lowest. I think I'm a big force plot guy, so figure 3 really kind of tells this tale, and I'm just interested in what the highest End-Tidal CO2 is, so I'm not even going to look at the minimum that you're reporting, because I think the story is the same. It's a little more magnified and comes out a little bit more in maximum. So what am I looking at here with the maximum End-Tidal CO2?
Similar to what we saw in the other figure, if the EtCO2, the maximum, is low, the odds of survival go way down, or the odds of mortality go way up, however you want to look at this. And again, there's this interesting effect as the EtCO2 values get really high that also doesn't appear to be a great thing for us.
Yeah, that is not what I was expecting. That is not what, I thought that it just didn't matter. This is showing a
no such
negative.
thing as too high, you mean?
Yeah. I thought too high just wasn't going to mean anything.
Oh, okay.
And in this
thought
case,
that was a good thing.
That's certainly the common wisdom, right?
Right.
Now, when I look at this, you report this, the association between End-Tidal and mortality overall, pre-ROSC and post-ROSC. Mm-hmm. And as I look at this, the pre-ROSC doesn't seem to really tell us much at all, which is rather unfortunate because that's when we're trying to make a determination.
That is the decision point?
Yeah. It looks like the changes, the association, either high or low, is driven almost entirely by post-ROSC. So really interesting. I'm still not sure what to do pre-ROSC, but I was not expecting that negative association, more mortality with high end-tidal CO2s. So we talked about that paper, that Levine paper, 1997, that looked at 100% sensitivity, specificity, negative and positive predictive value, end-tidal CO2 less than 10 at 20 minutes in PEA. Y'all, a secondary goal of this paper was to confirm that, to validate that.
See where we're at.
And do it with a much larger data set and with all rhythms,
Not just
PEA. Well, as I look at this graph, and I think this is, I had to dig into the supplemental.
I'm proud of you for going in those supplementals.
See?
Okay, but are you surprised, really?
No, not at all. Not even a little.
Well, I do believe she showed me up on the last episode. She dug into the supplementals, and I did not.
So he's not getting burned twice.
Okay.
Exactly. And what I found is some pretty graphs. I love pretty graphs.
I'm
That's
a fan.
definitely going on a slide. It does not look perfect, but what I see is if you're under 10 at 20 minutes, even though there are some patients with ROSC, vast majority do not have ROSC. And then if you look at survival, vast majority of patients do not survive. Not 100%.
And we wouldn't expect it.
We wouldn't. That was a little too good to be true.
Right.
So,
And that was a smaller sample, I think you already said.
Yeah. So, Remle, what were your takeaways from this?
My takeaways are primarily that the under 10 rule that we've been using is probably still good, but interestingly, we don't seem to go that low as often. Why? I think because we're focused on high quality CPR. We're doing compressions better. So yes, we can use it when it's there, but maybe we also want to think about some other things in our decisions to terminate.
Yep.
Too low is bad, but too high is also bad. And I think those are the key things that I pull out of this.
Okay. So, Dr. Abraham, what were your takeaways?
My takeaways are I'm trying to figure out why the high end-tidal is bad.
Yeah.
So this is kind of reassuring, right? Because I mean, the case earlier, like I'm comfortable with unwitnessed arrest, asystole,
right.
you know, that kind of stuff. But it's the patients where they have PEA or, you know, there was a shockable rhythm at some point, or it was the worst are it was a witnessed arrest.
VFib.
They've been they've been asystole the whole time, maybe a shockable rhythm once and then asystole ever since. They still have a high end-tidal. So I have a witnessed arrest and a high end-tidal, but we've been working for 45 minutes.
Right.
What do I do?
Yep.
So that's actually kind of comforting to say, hey, I have a little more justification for saying everything else in this picture is pointing towards you're not going to get them back.
Right.
You know,
I think Tanner, as he was writing this, by the way, my number one takeaway is, damn you, Tanner, you're putting us to shame again. I think that the way I was doing this, and I know our approach on this is similar because we've been sitting next to each other as we both did terminations from our crews. I know we think about this the same. And I think as I get to where I got advice on this, he gave both of us advice. I think it reinforces what we've been doing, and I think that's helpful. I also think when we were talking about this, both of y'all identified we're just not seeing low end-tidals. We're seeing an awful lot of really high end-tidals. Both of y'all said the same thing, but you said it really colorfully. Why are we seeing these?
well, so I work in Austin, right? And here in Austin, we have our third service EMS, and we have Austin Fire Department that first responds on our high acuity calls. The Austin firefighters do our CPR. The only other thing they do is play pickleball and work out, right? So hope they listen. Hi guys, y'all are great.
Nope, I'm not touching it.
But it works. I mean, they do fantastic chest compressions, and we have some exceptionally high ROSC rates and neuro intact survivals here in Austin because of that exceptionally good CPR. I mean, we know that early recognition, early defibrillation, and early high quality CPR are the things that make a difference. Well, Austin Fire Department contributes a huge part to that. But it also means these patients are really well perfused, even though they're somewhat dead.
Yeah.
And that gives me a lot, like I get a lot of these phone calls with all kinds of different rhythms and presentations with a high end-tidal, I think because we have such incredibly good CPR.
Don't really know what to do with those little bitty T-Rex.
No, I
arms, do you?
really don't.
We're back to this.
Screw you, they're really short, but I can hit the microphone if you keep shutting your mouth. So, I don't know if you know this or not, but a lot of EMS fellows listen to this podcast.
We're hiring.
Yeah, at least 2 of you. Thank you for listening.
Do you have a pickleball team?
Not yet, but that could be arranged if that would help.
I don't know.
I think
The fire department
sounded
might, I
fun.
don't know.
It
The fire
sounded
department probably
fun.
does, actually.
so. That was one of the most challenging things for me as a brand new medical director, taking what can be difficult calls.
Yeah.
What do I do with these persistent elevated CO2s? And the person who helped me the most, and this isn't the only thing he helped me with, this is kind of a common refrain, is Dr. Craig Manifold. So we were at an Eagles conference. We were at some conference. We were out to eat. And I took a call, and I came back, and I was looking a little distressed, and he said, Jeff, what's going on, man? You don't look good. And I said, well, I just terminated the arrest of a 45-year-old guy, witnessed arrest. We shocked him, but he had been in asystole for 50 minutes, but his End-Tidal was still 80. And that 80 was driving me crazy, but 40 minutes, 50 minutes of asystole, what were we going to save? And he said, well, first off, I would have done the same thing, and that helped a lot. But he also said, if the only thing that is keeping you from terminating is that End-Tidal CO2, and you need to sleep better at night because you do need to sleep well after you do this, just hold compressions. So you've already made the determination that this is futile. You're just trying to convince yourself that's the right decision. Hold your compressions, continue ventilating, give it maybe a minute. The End-Tidal will start to plummet. Mm-hmm. And now you have your answer, you feel better about it, and you can go to sleep at night. That has been 15 years ago, and boy, does that really, really help. So if you have not yet done your first termination, it's coming up. This will happen to you. Hopefully this will let you sleep a little bit better. So I think bottom line for this, number 1, screw you, Tanner. Number 2 is I think the Levine study has been validated. Nobody was going to get as good as that, but I think that probably means that wasn't really 100% really. But it's good enough. If you get a spike, well, look for ROSC, but if you don't find it, it's okay. Mm-hmm. It's not there. And then the persistently high End-Tidal CO2s might even be bad. And again, thank you for, helping me out, Dr. Manifold. All right. Dr. Abraham, you're on call, or will be. One of your partners helped out for an hour or so. Tonight at 3 a.m., you are likely to get a termination call.
Don't jinx me.
Is there anything about this paper that will help you sleep better after you do the termination?
Yeah. So I think the reassurance that a high End-Tidal, may not be, we've always viewed it as something positive and encouraging, and this paper kind of points out that may very well not be the case. Yep. I think it makes it a lot easier to terminate when everything else is pointing to futility.
Yeah, and just don't hang your hat on End-Tidal.
Yeah.
Perfect. Thank you all very much. Thank you all for listening to the first episode of Between Two Nerds, here brought to you by the EMS Lighthouse Project podcast. Guys, thank you all very much. If you get a chance to come to WAVE next year, definitely come. Great conference. You'll learn lots. Austin's a beautiful city. Come, and I will catch y'all on the next episode. Thanks a lot, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.